Welcome to our Fall 2022 Implementation Science Seminar Series. We're so happy to have you here. This is the 5th year that we have been doing these Implementation Science Seminars, and the 2nd year that we have been collaborating in Advance-CTR, the Brown Alcohol Research Center on HIV and AIDS, and the Department of Psychiatry and Human Behavior. So we're really excited to have so many of you present for our kickoff. I'm really excited to introduce Dr. Hannah Frank, who is our Associate Director of our Implementation Science Core in Psychiatry and Human Behavior, who will be co-hosting these sessions with me, as well as our speaker, Callie Walsh-Bailey from Washington University in St. Louis. So as an introduction, I'm just gonna get my notes up here. Callie Walsh-Bailey is talking to us today about de-implementation and implementation, two sides of the same coin or different sciences. Callie is a 4th year public health sciences PhD student and graduate research assistant in the Brown School at Washington University in St. Louis. Her research intersects implementation science, health equity, and chronic disease prevention and control. Her dissertation focuses on integrating health equity into implementation science methods and understanding how implementation strategies can be tailored and evidence-based interventions can be adapted through a health equity lens. She has expertise in systematic reviews and qualitative research methods and provides methods consultation on several studies in cancer control, obesity prevention, sickle cell disease, and other chronic disease areas. So without further ado, I'm going to pass it over to Ms. Walsh-Bailey to present to us. Before I do, just 2 housekeeping issues. One is, please put your questions into the chat. We will ask those questions at the end. And as you are thinking about your questions throughout the presentation, please put them in there. You don't have to wait till the end. And second, at the conclusion of the Q&A, we are going to have a short survey that we need you to complete. So please don't leave until you do that. Okay. Now we'll pass it over on to Callie Walsh-Bailey. Thank you.
Thanks so much, Ronnie. And thank you all for coming. I'm really excited to get to speak with you all today, and was really thrilled when I got this invitation to come. So full disclosure, I do not consider myself an expert in de-implementation. As you heard from that intro that Ronnie gave, that did not come up. So I started my career in implementation science as a research specialist at the Kaiser Permanente Washington Health Research Institute, where I worked with a few implementation scientists and kind of got a taste of the field and loved it so much that I decided that I wanted to be one of them when I grew up. And so I came back for my PhD. So I actually, one of my first studies was called Taking Action on Overuse, and got to do some really great qualitative work on that. And that was really focused on de-implementing low-value care in clinical settings. And so I was kind of working on de-implementation before I really had the language to know what that was. And so I was really excited when I got to work on a systematic review, digging into that space a little bit deeper. But I think there's many of you on this call that probably have a lot more expertise than I do in this area. And so I hope that we'll save plenty of time towards the end for lots of rich discussion. So just to give you an overview of what I'll be talking about over the next 30 to 40 minutes. I'll give just a really brief kind of summary of 3 recent systematic reviews of de-implementation theories, models, and frameworks, including one conducted here by our team at WashU. So I'll go a little bit more in depth with this one. And then I'll share a couple of examples of frameworks applied in de-implementation studies. And then wrap up with some of kind of my half-baked thoughts, as well as some implications and future directions for the field, and then hopefully have a good amount of time for discussion. So first, I just want to acknowledge that the practice of undoing is not new, nor is the study of this. Policy termination and disinvestment, for example, have been the subject of inquiry in public policy and political science for at least the last 50 or 60 years. However, as a field, D&I is relatively new, and so de-implementation within that is still a pretty understudied area. These data are a few years old now, but between 2000 and 2017, only about 3.5% of NIH and AHRQ funded research for implementation was focused specifically on de-implementation. So a very small sliver of our implementation science pie. Daniel Niven and colleagues published the first review of de-adoption and de-implementation terminology in 2015, so not that long ago. And the first review of de-implementation frameworks was only published in 2020 by Per Nelson and colleagues, and their review searched the literature from 2013 to 2018 and located 10 examples of either proposed or empirically used theories, models, and frameworks to study de-implementation. Parker and colleagues published the most recent review earlier this year, which extended on Nelson and colleagues' work. And they really focused on reviewing how those theories, models, and frameworks have been applied in the study of de-implementation. So those two reviews look broadly at implementation science frameworks. And so our team took a little bit of a different approach. We looked beyond just public health and healthcare, looked at a lot of other fields because we know there are other folks doing this work. And we were looking very specifically for models and frameworks that were developed for de-implementation. So rather than all of our implementation science frameworks that may have been applied to the study of de-implementation, really looking specifically at what do we know about what's been studied for de-implementation in particular. So across the three reviews, we've located a total of 42 unique theories, models, and frameworks that have been applied to de-implementation or conceptually proposed to be applied for de-implementation or related concepts such as policy termination, technology obsolescence, disinvestment, et cetera. Of those, 30 specifically were developed for de-implementation, so about 70%. And only 13 of those 30 have been applied empirically. So over half have been proposed conceptually, but haven't been tested in any sort of research. In all three of our reviews, frameworks were primarily focused on identifying or characterizing determinants, so our barriers and facilitators to de-implementation. And the theoretical domains framework was most frequently used for this, which to me suggests really a focus on individual level determinants of de-implementation. The second most common kind of type of framework or purpose for a framework was to conceptualize or delineate the de-implementation process. So through what steps or stages does de-implementation occur? And kind of surprising, but maybe not super surprising, there were only 3 frameworks that were characterized specifically as evaluation frameworks. So we can use some of those determinants frameworks or process frameworks to do some formative evaluation to see if there's changes in determinants over time. But we really only have 3 frameworks that we found that were either proposed or have been used to assess outcomes of de-implementation efforts. So I'm going to focus in a little bit more specifically on our team's review. And if you see that QR code down in the corner on these slides, that'll take you to our review paper if you're curious about learning more. And I just want to acknowledge the wonderful team of co-authors that I had working with me on this. So it's a lot of fun diving into kind of a newer area. So this was a scoping review. So we're not trying to provide specific recommendations or assess the overall quality or utility of these frameworks, but really just to provide a high-level overview of what's out there. So we tried to map where these de-implementation frameworks are coming from, how they have been used empirically, or their suggested or intended uses if they were proposed conceptually, and some of their kind of levels of applicability. And then wanted to summarize some gaps and point to future directions for framework development and de-implementation research. So we started with a total of 860 records, and ultimately we ended up with 27 full text articles for extraction, which included 27 unique theories, models, and frameworks, with the exception of one collection of studies, which I'll talk about a little bit later. Each framework was unique to each paper that we found. In our review, 13 of the frameworks that we found were from empirical studies, and 14 were from non-empirical articles. So again, only around half of those models have actually been used in research. All of the articles that we included that explicitly stated a country or a region for their work all represented high income countries. So the US was the single most common country, followed by Australia and Canada. And 22 of the 27 papers focused on healthcare or public health settings, mainly in clinical settings. So there are relatively few community or other non-healthcare settings represented in this sample. For each of the articles, we evaluated what kind of evidence the authors cited for de-implementing the particular intervention, policy, practice of interest, or what kinds of evidence they cited as rationale for de-implementation if it was discussed more conceptually. So these first four types of evidence you see come from an article that Ginger McKay and colleagues published in 2018, and then were later refined in a commentary by Wynn Norton and David Chambers in 2020. And then our team added two additional kind of more pragmatic reasons for de-implementation, which were stakeholder input and cost. We found that 15 of the 27 articles cited empirical evidence to support de-implementation. Of these, evidence indicating that a practice was ineffective or harmful was the most common type of evidence, which showed up in 12 articles. And 5 of those also cited evidence that a practice was contradicted. So earlier evidence suggested that it was maybe more effective than more recent or more robust evidence did. So those were some sort of medical reversal. We found 20 articles cited stakeholder input, so perhaps from patients or from physicians or other folks who were affected by potential de-implementation as some sort of support for de-implementation. And all but 4 studies cited cost as justification or rationale. And this seems to be in alignment with the broader literature on de-implementation, as there's a lot of focus on reducing costs associated with low-value care. And in other fields, such as business, continuing to use an obsolete technology can be really costly to organizations. And so cost is a significant driver of kind of reassessing some practices and maybe removing some or replacing some. So speaking of removing and replacing, the other information that we coded from the frameworks and the articles we located were what I call these 4 R's. These terms come from the Norton and Chambers 2020 commentary to guide the characterization of de-implementation targets, or what types of de-implementation outcomes that the model was applied to. So removal refers to complete elimination of a practice or policy intervention. Reduce means doing less of something, so reducing frequency or intensity. Restricting, this is when a scope of an intervention is narrowed. So this could be something like going from a universal screening approach to screening high-risk patients only, or limiting the types of settings an intervention can be offered in. And then replacing means stopping one practice and swapping it out for a new one. So we identified 2 different kinds of action targets from the frameworks in our review. So primary action targets were the ultimate goal or outcome of de-implementation, and some studies and frameworks had multiple primary action targets. For example, a framework presented decision trees or multiple pathways, and depending on kind of the context and which route you went down that decision tree, you could end up with one of several outcomes. We also coded for secondary implementation actions. So these are intermediate steps along the way to achieving the ultimate desired implementation outcome. And we found that the majority of studies sought to completely remove or eliminate a practice or an intervention. So for example, deprescribing a medication a patient no longer needed or was believed to be harmful. Reduce was the second most common action target. So de-implementation sought to cut back on an intervention, but not eliminate it entirely. So for example, reducing unnecessary preoperative tests for low-risk surgical procedures. And fewer studies sought to replace an ineffective or unnecessary practice with something that's more effective. And if we have time, I would love to talk about this at the end, because this is something that really surprised me. And this will come up a few more times in this presentation. We also coded the levels at which the models operated, and we found that 21 frameworks operated at multiple levels, and 4 of the 6 models that considered just a single level did so at either the organization or the system level, so still indicating that there's some higher level factors going into de-implementation rather than it being an individual decision or process. And this finding is a bit different than the other 2 reviews that I mentioned that had more framework examples applied specifically at the individual level. We also found that about 2/3 of frameworks depicted linear relationships between constructs, while more complex relationships like feedback loops or nested relationships appeared less frequently. We found a few frameworks that presented constructs in a table but didn't depict how these related to each other. So a little bit of ambiguity there in those cases. So these are just a few high-level reflections from the discussion of our review paper. Again, over half of the frameworks we found haven't been applied to guide de-implementation research in practice. And so the field is really rife with opportunities to test and refine these models. And so rather than reinventing the wheel, we suggest that researchers apply or adapt an existing model rather than creating a new one whenever possible. And this will help us grow the evidence base for de-implementation and foster learning across studies. In general, the studies and the frameworks included acknowledge the complexity of de-implementation. And for the most part, models reflected this by operating at multiple levels. However, we know that change is not an easy nor linear process. And so although it's a helpful heuristic to have steps kind of lined up nicely in sequence, this can maybe obscure some of the complexities that we would see in practice, may not reflect the iterative nature of de-implementation. And so there might be other opportunities for refinement and to kind of build in some of this complexity. Again, there are decades of research on policy, disinvestment, reassessment, termination, and other fields, but learnings from these have yet to be widely integrated into de-implementation within our D&I field. One limitation of our review is that even though we went out and looked for these, we didn't really get as many as we expected to see. This could be because they're published in books or in other non-peer-reviewed sources, so they didn't get picked up in our search. But this suggests that perhaps a more robust systematic review that does search some of those non-peer-reviewed and gray literature sources might be warranted at this stage. And finally, when choosing a model to guide de-implementation, we suggest that readers might find our review helpful in identifying models that target the same de-implementation actions they're interested in. And so one of those 4 R's, and operate at the level at which they think their de-implementation determinants or processes occur. So I'm going to spend just a few minutes highlighting a couple of examples of frameworks that have been applied to this study or can be applied to the study of de-implementation. And the first is going to be a framework most folks are probably familiar with, so REAIM, which is the Reach, Effectiveness, Adoption, Implementation, Maintenance Framework. So I'm going to provide an overview of a study that uses REAIM to guide the evaluation of a de-implementation protocol within the context of a larger implementation trial. So this work is being led by Terrence Swindle and colleagues and is focused on implementing evidence-based feeding practices in early childhood education settings. So the types of feeding EBPs they're looking at include things like introducing children to new healthy foods and facilitating exploration of those and modeling healthy eating behaviors. And the authors acknowledge that in order to implement those EBPs, they have to remove detrimental feeding practices to make way for those more effective evidence-based practices. And so some of the practices they're trying to remove include pressuring children to eat quickly or greater quantities, which we know can lead to overeating and poor dietary quality. So the goal of their pilot is to develop approaches aimed specifically at de-implementing these detrimental practices. And the authors acknowledge that implementation and de-implementation are distinct processes that require some unique strategies. Their main outcomes for de-implementation are looking at the feasibility and acceptability of those de-implementation strategies. And they propose to develop those in collaboration with the practitioners in these early childhood education settings. They are going to draw on the ERIC implementation strategy compilation, and those will be specifically tailored to the de-implementation context. Since this is just a protocol, we don't know what those strategies look like just yet, but this will definitely be a study that I'll keep an eye out for, because I think they'll have some really interesting results. So they use REAIM to evaluate their de-implementation outcomes and the effectiveness of their intervention. And we can see that the A and the I in REAIM have been modified to focus on de-adoption and de-implementation. So the authors indicate that they'll use observational data to assess the number of detrimental feeding practices versus EVPs, a total of 4 times over the course of their study to see how those change over time. And of course, they would be hoping to see that over time, those detrimental feeding practices would drop off and would be replaced with those evidence-based practices. They're going to use mixed methods data to look at de-implementation. So the acceptability of intervention measure and feasibility of intervention measure developed by Brian Weiner and colleagues in survey data. So those are quantitative measures. And then they'll do interviews to determine kind of more of the context around the acceptability and feasibility ratings for those de-implementation strategies that are developed. And then for maintenance, they'll be looking at how well those EVP components are maintained and the detrimental feeding practices continue to remain out of use further along in their study. So kind of my high-level reflections, these outcomes are somewhat similar to what we would expect to see in an implementation or hybrid study, again, with the exception of the primary focus on practices that are subject to de-implementation. And removal is a supporting action to ultimately get to replacement. And again, this is interesting because we really didn't see very many examples of this when we looked at our studies that had de-implementation specific models. So they're doing replacement here, but we didn't see that come up as much in our review. I'm going to highlight just a couple of brief examples of de-implementation specific frameworks from our review. And so these come from the SHARE study, which is a group in Australia that have been working on developing some methods and measures for reassessment of practices in healthcare systems and potential disinvestment of practices or of resources that maybe are not the best use and reallocation of those resources into more effective practices in the healthcare system. The authors conducted a literature review of disinvestment frameworks and found that there was really no systematic framework to guide and assess disinvestment. And so they decided they were going to create their own. So there's a lot going on here. We're not going to get too much into the weeds, but I just want to call out some of the similarities that we would see in some of our other common implementation science frameworks, and maybe a few things that are unique to the de-implementation or disinvestment context here. So kind of their big buckets of determinants, they're considering external environments as well as organizational environment. We might see these things come up in CFR, for example, in the inner versus outer setting. They also look at characteristics of potential adopters of a de-implementation practice or kind of a new practice that's coming in as a replacement, as well as the potential recipients, which again, aligns with some of our implementation frameworks, as well as resources for implementation or de-implementation. Some of the things that might be a little bit more unique to this disinvestment context are kind of this identification process, which refers to kind of the steps or the approach to looking critically at some of these practices that are subject to reassessment, potential disinvestment and replacement. As well as the prioritization and the decision-making process around that. So that's called out maybe a little bit more than it would be in some of our typical implementation frameworks. They also include some of these stages of change, which we're used to kind of seeing stages in our implementation and clinical research, but these might look a little bit different than what we would typically consider. But they are looking at some processes and outcomes that are going to be similar. So things like fidelity, the degree of practice change, changes to patient practitioner system outcomes, sustainability and spread, which again, this kind of reinvestment or reallocation of resources as something that's unique to this context. Again, a lot going on, so not going to get super in depth here, but just wanted to call out again, if we're looking at some of these kind of labels for their determinants that they're interested in, again, a lot of overlap with some of our implementation frameworks with some potential differences. Again, maybe looking a little bit more at these proposals for change in particular. So kind of what they're looking at in terms of maybe level of support for de-implementation or reinvestment, kind of the nature of the problem specifically focused on harm or lack of evidence, and looking specifically at disinvestment, as well as maybe some more of these kind of SMART objectives. Opportunity for reinvestment is going to be, I think, a little bit more unique to this de-implementation context. And I know this is a bit blurry on the slides, but again, just want to call out a few of the outcomes that they suggest that folks can look at when assessing disinvestment, reinvestment of resources. So again, degree of implementation, so target groups reached, sounds a lot like reach and penetration. The activities delivered as planned, so that could be similar to fidelity, looking at degrees of practice change, including attitudes, intentions, behaviors, a lot of kind of practitioner focused outcomes we would often look at in implementation. And specifically focused on economic costs. Here, timing, so kind of when do things happen? So a lot of similarities, but also maybe some unique outcomes to the de-implementation context. So just a few reflections on frameworks, not only from our review, but kind of looking more broadly at the implementation science literature. There's only a couple of examples there, but it seems like our existing implementation science frameworks can be operationalized for de-implementation with probably some exceptions. So we have to think about how different are our de-implementation determinants, the processes or the steps through which de-implementation occurs, and some of the outcomes we're interested in to see if we can really match one of those existing implementation science frameworks or if a unique framework to de-implementation is warranted. There's certainly a lot of room for testing and refinement of our de-implementation specific frameworks. And we noticed variable quality of these in our review. Some of these are very robust, have very well defined and operationalized constructs, while others are pretty high level, maybe not very well specified and haven't been applied. And so maybe not a lot of guidance of how one might actually apply that. A lot of those de-implementation frameworks have been developed for very specific topics or contexts. So for example, and we saw a lot of frameworks coming out of clinical settings. For example, medication deprescribing is a big one. And so it's not really clear to what extent those are generalizable or can be transferred from one topic or setting to another. And probably not surprising because this is a common issue in our implementation science literature, that we're really lacking robust pragmatic, valid measures. So lots of opportunities in this space. So to get into this question, are we really working in the same science when we're talking about de-implementation, or is implementation really that different from de-implementation? The literature is mixed. I think there's a growing consensus in the field that there are some kind of unique differences to each of these, but also some overlap. And so I think there's kind of this ongoing debate of the extent to which these are different. So there are some shared characteristics in de-implementation and implementation. So those who are more open to new evidence, for example, might be both early adopters of an intervention as well as early de-adopters or de-implementers as new evidence comes out that perhaps refutes existing evidence or suggests that there's another practice out there that's more effective. We might have some different determinants for de-implementation. So organizational factors such as the structure of an organization or culture and climate are more often associated with de-implementation, at least from one review. Whereas de-implementation is often going to be driven by some psychological biases, or those might be barriers more frequently. So things such as confirmation bias. So practitioners favoring evidence that supports their existing beliefs rather than new evidence that maybe refutes those, or loss aversion bias. So folks being more concerned about potential losses of not doing something or doing something different than they are satisfied with the gains of de-implementation, as well as feeling threats to professional autonomy. And this came up in my work at Kaiser with Dr. Michael Parchman, who led the Taking Action on Overuse study. He's a physician researcher and would often say that in medicine and in public health, we're in helping professions we're used to doing. And so it's really difficult to tell a doer, don't do this or do less of this. And so often thought that you really need to, if you're taking something out of a provider's hand, you need to replace it with something, which again, we didn't see as much conceptual guidance in the frameworks that we found in our review to kind of show us how we do that or how we think about that. Christian Hofrich and colleagues have a great paper showing a dual process model of human cognition and the ways in which that can be applied to de-implementation. And they suggest in their review that process of unlearning is going to be based a lot more on reflection. A process of substitution is going to be a little bit more automatic, and that the processes of learning are often different than the processes of unlearning. And so we might need some unique strategies or approaches in order to be successful in the implementation. A lot of folks here are probably going to be familiar with this diffusion of innovation kind of bell curve. And so we see innovators and early adopters, so the folks who are really early to pick something up. And we have kind of late majority and folks who are lagging on the tail end of that. And Dangler and colleagues suggest that we can also apply this to de-implementation by proposing that as an intervention or policy practice wanes in popularity or use, that a small number of kind of early users are going to de-implement that intervention, with that de-implementation advancing more rapidly after reaching a tipping point among these early adopters. So kind of a similar tipping point that we would often see in implementation. As with strategies targeting adoption and implementation, strategies that can expedite that de-implementation process can help us really kind of get that curve to get a little bit more steep. And they also kind of conceptualize this as just a natural ebb and flow cycle in clinical practice in particular. This is a study in surgical settings. So they kind of say there's this natural process of new practices coming in, evidence for new ways of doing. And as those things come in, we need to get rid of kind of the way we were doing things before. And so there's kind of this ebb and flow that goes together. And of course, since health equity is near and dear to my heart, I can't leave you all without posing at least a couple of thoughts about how de-implementation and health equity fit together. There's a lot of questions for the field to grapple with. De-implementation in general is relatively understudied, as I mentioned. Health equity is a rapidly growing area, but we still have a lot of work to do. And so putting these things together, there's not a ton of guidance out there for how we think about these things. Both Christian Hofrich and Rachel Shelton have a couple of really great papers kind of grappling with some of these questions. And so I encourage folks to read those if you're curious. But some of the things to think about are, when is de-implementation harmful and to whom is it harmful? In the Shelton paper, they look at updating cancer screening guidelines, particularly among African-American populations who have a lot of distrust with the healthcare system for a lot of very valid reasons. And so if you're kind of changing information, if you told someone that things are one way and then you're coming out and saying, hey, we're actually doing this differently, what does that do to some of those relationships that have already been damaged in other ways historically? On the flip side of that, de-implementation might be able to advance equity. For example, the Helfrich paper highlights a couple of well-known examples of practices that are harmful to historically marginalized populations and point out that often low income and low resource populations often subsidize the care for higher income populations. And so there might be some opportunities to leverage de-implementation to advance health equity. And I want to just call attention to a resource that many folks might already be familiar with. This is the Dissemination and Implementation Models web tool that has been collated by colleagues at WashU, as well as University of Colorado and University of California, San Diego. And we've been doing some updates on the site over the last year, which will kind of iteratively come live and be updated over about the next year or so. And one of the things we'll be doing is adding some of those de-implementation specific models from our review to this website. So folks will be able to search for those in this web tool in the next few months. And we have about 20 minutes left for questions, so I want to stop there and just say thank you all so much for listening, and would love to open it up to chat and hear some of your thoughts or experiences from your work in de-implementation.
Callie, that was terrific, and it was so great to see you present such a wide range of views on de-implementation and also focusing on health equity as well, which I think a lot of people here appreciated hearing about. We have some questions. So the first one is, sometimes in developing country contexts, instead of de-implementation, new strategies are superimposed simply because the de-implementation idea is not understood. What would be your advice to engage policymakers to the needs of de-implementation? Wow, that's such an interesting and important piece. And obviously also thinking about the global health context as well.
Yeah, that's a lot to grapple with. And I would not say that global health is my area of expertise. And so take this with a grain of salt as I kind of formulate my, my thoughts on the fly here. But I would say this is where I think those community grounded partnerships are so, so vital, because we should really be identifying priorities from the affected communities. And oftentimes there might be something that works, maybe doesn't work quite as well as something else. But if we think about Enola's implementation outcomes paper has that really great kind of formula heuristic for getting us to think about what is the right combination of implementation outcomes. And I think we can also apply that to de-implementation outcomes that, you know, especially if we're thinking about replacement, maybe there's a practice that is slightly less effective, but people really like it and they're going to adhere to it. And taking that away might, again, you know, going back to the Shelton paper example, cause some harms, some unintended consequences. And so I think we need to consider that really carefully and kind of weigh the costs and benefits of de-implementation and really have communities drive those priorities. And then kind of leverage our position as researchers to communicate with the policymakers to set those priorities. But I don't think those should be superimposed by us as researchers.
I have a question about replacement later, but I'm going to ask that later after other people. So we have some other questions for you in the chat. So someone says, this is really awesome research. Thanks for this great presentation. I'd be curious to hear your thoughts on how these insights might help us as researchers advance our own science and practice. For example, as you've mentioned, D&I and health equity are rapidly growing fields. How can we work to de-implement our own research methodologies or frameworks to adapt or adopt practices centered on bolstering equity and the impact of our work? I've not thought of it that way before.
Yeah, I love that question. Oh gosh, that's a lot to chew on. I think that HealthRich example is one great way of like kind of how can we hack our brains? How can we use this really great cognitive research that folks have done about the processes of learning and unlearning, or kind of substituting one way of doing and thinking with another. So we can kind of train ourselves to, okay, what are the maybe strategies we need to use in our own research, in our own labs, to think about things in a new way. And since I do a lot of qualitative work, one of my values in research is really approaching questions and issues with a humble learner and listener hat. And so I try not to come into situations as, oh, I'm the expert researcher and I know exactly how we're going to do this thing. And more of, okay, what is the issue? Let's hear a lot of different perspectives. And what can we learn from this? And so I think maybe some kind of humility and humble listening and learning can go a long way, especially if we're thinking about a lot of the ways that we have historically done research have been harmful. And I think that we need to sit with discomfort and acknowledge that so we can unlearn some of those things and hopefully replace with better ways of doing and knowing.
And I'll just leave the chat for a second just to say, because you just mentioned stakeholders. And one thing that really struck me right in the beginning of your presentation is that when you said that when you were looking for evidence for de-implementation, that you added two pieces to framework, and you mentioned stakeholders and cost. And I thought to myself, this is fascinating. How were those not included before? And I just feel like, what you've just described with, listening to stakeholders, learning from those on the ground is such an essential piece. So I don't know if you have anything to add to how that has not been part of this previous work.
Yeah, I think one thing that came up a lot in our review was, I think especially because a lot of this de-implementation work has been done in clinical settings, it's often provider focused. So how do you change individual provider practices? And so those are the folks whose opinions are often represented, or kind of the folks that you engage to get some of this both implementation and de-implementation work done. I think one thing I forgot to mention in that slide about maybe some of the similarities and differences is those roles for implementation and de-implementation are often different. There's literature that suggests that it's really kind of on the ground practitioners, those frontline folks actually delivering interventions who are often involved in implementation, whereas de-implementation is often driven at a higher level. It's like the organizational level leadership, that can be policymakers who are kind of, again, suggesting new ways of doing things, or, we're not going to do things this way anymore. And so I think we really need to consider those multiple levels of, who's making the decisions and who actually has to enact those, but also who's going to be affected. We did see a few examples that included patient perspectives. So, for example, shared decision-making conversations around e-prescribing. But we didn't see very many kind of community-focused de-implementation articles come up in our review. And so I think, from my public health perspective, those are always huge missed opportunities. I think and I know that the term stakeholder can be a little bit tricky, but I think we need to consider a wider audience of who do we get involved in these conversations and who is affected, and make sure that their voices are represented.
There's another comment in the chat, and I think there might be a word missing, so I apologize if I'm saying this incorrectly, but at which point would you think about exploring de-implementation when delivering a mental health intervention in a community and primary healthcare setting? I think you were kind of just getting at that, almost a foreshadowing of that question.
Yeah, that's a great question. And I have worked with a lot of really wonderful folks in the mental health space, and this is not at all my area of expertise. So Ronnie and Hannah, if you have thoughts, put thoughts in the chat, I might turn this question back to folks. This is, again, me kind of speaking off the cuff and not necessarily, from the literature, but I think we should be constantly kind of critically evaluating how we do things, and looking for evidence that suggests things work just as much as we should be looking for evidence that suggests like maybe things quite aren't working the way that they are. And I think especially some of these more rapid methodologies that are gaining popularity in implementation science can help us do that. So we can kind of iteratively refine our approaches over time and kind of learn in real time what's working and what's not. Yeah, would love other thoughts on that.
Well, I was just going to say, and Hannah can say other things too, but one thing that we've been doing in our own mentoring groups is talking about the website Choosing Wisely, or the organization Choosing Wisely, and going to their website, which Callie, I'm sure you are familiar with this, but it's not as much public health focused as more clinic healthcare focused, hospital based, but just a great place to look at like what is low value care, and what shouldn't be done. And some of it could be harmful. Some of it just could be like adding costs, but not adding any value. And so you could, if you're working in the area of, say, critical care medicine or even psychiatry, you can look to see what are the practices that are considered evidence-based, but are done now just because no one has taken the time to actually say, we don't need to be doing these. They don't add any value. And at the very least, they don't add any value. And at the very worst, they could actually be harming people. So that Choosing Wisely website is a good place to go. We have another global health question, which is how can resource poor settings address issues of economic constraints of going through de-implementation? Are there any cost effectiveness studies of taking that path?
Yeah, that's such a good question. The short answer is there probably are. And I can't name any off the top of my head, especially in kind of low resource, low income settings. What I can say is I think that that's all the more reason for kind of this critical appraisal and these kind of reassessment questions, which again, that SHARE study that I provided an example of, I think, some of those concepts could probably be applied to low resource settings. But if there are so few resources and, you really have to think about, where are we getting the best bang for our buck? That might, and again, going back to, cost really being one of the significant drivers of de-implementation, as well as kind of that stakeholder input, thinking about, what can we do with the resources that we have? Where are maybe some of the opportunities that we're not using our resources to the best of our abilities, and we can kind of streamline things, or maybe get rid of some things that just really aren't working, especially even if they're not causing harm, and people are just comfortable doing them. Maybe we can kind of cut some of that fluff.
Another question, another person says, thank you so much for the great talk. And the question is, while the work in de-implementation is growing, oops, I just lost it. While the work in de-implementation is growing, what would be your take-home messages to clinical systems when they need to work on de-implementation of low value or harmful care? I think you were just getting at that.
Yeah, and I think, Ronnie, you raised a couple good points. So I would say, going to existing resources, Choosing Wisely is a really great resource. Folks at Kaiser Permanente Washington that have worked in the taking action on overuse space have really great resources on preparing clinical champions for de-adoption and de-implementation. Maybe I can multitask and find a link to put in the chat for you folks. But I would say, start with those existing resources. I think JAMA may also kind of publish medical reversals, but there are certainly some systematic reviews out there that kind of highlight some examples of those medical reversals. So I'd say, start with that existing evidence. And then again, I think it's going back to, who do we consider, who has a seat at the table making these decisions? Whose perspectives do we consider when making these decisions? And thinking really critically about who has been missing, so we can make sure that we hear from folks, and whether we make a decision to de-implement and replace, or just get rid of something, or kind of reduce something, making sure that we are getting perspectives that are going to help us maybe identify some of those potential unintended consequences and potential harms of de-implementation, so we can plan from the onset for those.
And Hannah just replied in the chat with all sorts of resources about the question about when do you consider, de-implementation in the mental health space in community settings. Do you want to add anything more, Hannah, about that?
Yeah, sure. I mean, I can just briefly sort of summarize what I put in there in response to that mental health question, which is something I think about a lot. And I think that to me, if something is iatrogenic, then I would more immediately think de-implement, though I would, of course, want to make sure that we have confidence in that conclusion for all populations. And the other thing that I mentioned, and of course, this is my example given my area, which is exposure therapy and CBT for anxiety, is that we know that relaxation, for example, is not actually a harmful practice, and that clinicians really have a tendency to prefer delivering relaxation over exposure, where exposure is known to be an active ingredient. And so that's a place where we may want to reduce relaxation. So that's like one of those types of de-implementation that Callie was talking about, where we want to reduce relaxation because it may be preventing people from implementing the key thing we want them to implement. So those are a couple examples and considerations with mental health interventions. I do think it's more complex a lot of the time than if you have a more circumscribed thing, like medical tasks that you want to remove or de-implement. But that's a few of my thoughts on that.
And I think something else that doesn't come up, but often goes hand in hand with de-implementation is misimplementation. And so we've implemented things, but that implementation really hasn't gone well, or we're not necessarily implementing the right things. Ross Bronson has some really great work on misimplementation in public health in particular, and the new version of that D&I book that he and Anil Proctor edit has a chapter on de-implementation and misimplementation. But I think those are kind of some other opportunities. Is what are maybe some things that work really well in practice, but have been maybe discontinued prematurely when it's like, oh gosh, no, we really needed to keep doing that, or maybe just isn't used in the right context. And so I think kind of looking at some of those opportunities as well.
And thank you, Callie, for putting in the taking action on overuse link in the chat for people to see. And your last comment made me think of something else, that when you were talking about the share work, which is really fascinating, and we did put the link in the chat for people because there was some interest in it. And I was really taken with the disinvestment term, and it brought me back to Wynne Norton. I think she did a review some years ago about all the different terms that are being used in the de-implementation space. And what does that mean to you in doing this work? Like, how do people conceptualize this work if you're using words like de-implementation, disinvestment, de-adoption? Does the meaning change at all?
Yeah, that's such a great question. And I think Daniel Niven and colleagues do a really good job of kind of grappling with this as well. And that was something else that we did in our review, is kind of map all these different terms that are being used. I kind of think of de-implementation as an umbrella term for a lot of these other things. And especially if we think about, adoption and implementation in our implementation science space are kind of distinct phases. And so when we say de-implementation, we might actually be thinking about earlier phases of de-adoption. So kind of the left-hand side of that bell curve. Disinvestment and termination in particular come a lot more from the policy space. And the disinvestment piece in particular tends to come when there's that financial component to it. So a lot of studies talk about kind of reassessment, which is maybe a precursor, maybe our preparation phase for de-implementation, but looking critically at, what practices are we maybe misusing, that we're spending too much money or resources on that really just aren't helpful, and kind of making a decision. And that's why we saw some models that kind of had, multiple pathways to get to a de-implementation outcome, because it could be, restricting the scope of practice. So maybe a different environment could be just reducing it. So we're not going to try to get rid of it entirely, but we're going to maybe give it to a more narrow population, or that replacement, or you might assess it and be like, no, this is something really valuable and we're going to keep doing it. That share work I think is really interesting for that, because it kind of shows some of those different pathways.
Well, this has been a tremendous talk. I'm so happy that you were able to kick off our series for us. I want to give people time to answer the survey that they're going to receive once this closes. But at the same time, I want to just thank you, Callie, so much. We're looking forward to following your work in this area much more, given that you have so much of your career ahead of you. And just say thanks so much for being with us. Also, everyone, there's a link in the chat for the next talk, which is from our own Hannah Frank next week on implementation mechanisms related to implementation strategies. So we've got a lot of other great seminars coming up. So please continue to join us, and a round of applause virtually for Callie. Thanks so much for being here.
Thank you so much for having me and for the excellent questions. I love getting to talk with folks as I leave with much more food for thought than I came in with. So this is great. I get to learn a lot from you as well.
Thank you again. Take care.